in my country, when we discuss in depth with patients, we say that we are discussing about clinical picture. And you see picture, and in fact, human beings are used to classify picture. Just to have a look of that, there are 6 pictures, and I'm quite sure that some of you will say that these 2 one are close to each other. These 3 one are close to each other, and perhaps this last one is a little bit apart, but close to this one. And in fact, with disease, with disorder, for hundreds of years, physicians just did that. They classify with their eyes, and this is what we call disorders. Of course, there is a big question with art movement. Do we consider that at a given moment some people thought about arts and they say, now we are going to decide that there is impressionism and we are going to draw picture like that, or whether it is the contrary. Perhaps at a given moment some painters just paint like that and they meet all together and they say, well, in fact, we are now creating what we call impressionism. And this is an open question. This is a question about nominalism versus realism. Do art movements are just words on categories of picture, or do they are reality? And this is exactly the same with disorder. And we don't agree. And we are going to do a survey. Who think here that classification, disease, are mainly words that we put on phenotypes, or whether you consider that mental disorder do exist in reality? Yes, mostly. Here it is nominalism, here it is realism. So mainly you are nominalist, I am too, but many colleagues are also realistic, and this is open to discussion. Anyway.
How about this one?
Yes, yes, yes. Skepticism. No, both of them. Yes, and you see, this is why I put the arrow in both directions. Perhaps both directions are true. Yes, sure. But there are many ways to classify picture. Here, for instance, you have non-figurative picture. Here you have figurative picture. And at the middle you have figurative, more or less figurative picture. And so you have some kind, you may have some kind of continuous classification. And in child and adolescent psychiatry, we have continuum too, possibly. And you can also classify picture with the technology that is used to do the picture. You have pastels, charcoals, oils, and you can say this is an oil, this is figurative, and you have many ways to classify picture. And in fact, we do exactly the same thing with our patient. We have many ways to classify patient. We have psychopathological theory, for instance, psychoanalytic or cognitive, and there is a classification, the PDM2, which is based on psychopathology. We have symptoms, of course, physicians love symptoms, and there is the DSMs or the ICD, which are based on symptoms. You have biology that can produce classification. You have the RDoC, which is a classification based on biology. But we forget from time to time that age, of course, is very important. And because age is less important in adult psychiatry, and classification comes from adult psychiatry, we forget too often that, of course, we know that when a child is 2, 5, 8, 10, 13, 18, things are quite different. And because development is very fast at this age, symptoms can move, and the way they move is a part too of classification. And so it makes things complex. And we forget also society, and Janelle shows that whether you come from a particular culture, even a religion, even the society itself adds categories. You know, in the societies, the word schizophrenia exists, and it has not the same meaning as we consider schizophrenia. But this is reality. This is the way where society considers classification of people different in their mind. And so this is what we have to do in our work every day. We have to classify, and we are going to see why, but classify words. We have to speak about our patients. And when we speak, we classify. But we have to remember that these classifications are basically potentially very complex. And this is even more complex as we love classification. We love classification. This is a power for physicians to be able to say, you are an autistic people. This is autism. And even in my country, only physicians are able to pronounce diagnosis. This is crazy, but psychologists in France are not allowed to say a diagnosis. So there is some power, some authority in the way we use diagnosis, and we love power and authority, of course. Diagnoses are also big words. You know, when performative things, when you say you are autist, this is likely to modify the person to whom you say you are autist. There is evidence about that. And so sometimes it is for the good, sometimes it is not for the good. And so we have to use it very carefully. When you have to do scientific research, most of the time you have to define inclusion and exclusion criteria. And so you have to use categories and classification. And at the end, it becomes a self-fulfilling prophecy. If you use classification to include patients in trials, then you have results for people that are classified. And so you treat them as classification, because data are related to the classification. And of course, we need scientific research. We need that. But we have to realize that these classifications are only tools that make it possible to do research. But at the end, when we use the results, we have to come back to what we have in front of us. And also, classification can be defensive mechanism. That is, when you have a complex situation in front of you, life is not so easy. And so when you decide that situation is not so complex, this is borderline personality disorder, and so I have to do that, life is easier. And so you believe at the end that classification tells the truth. And because of that, there is a temptation to become experts, mega experts in classification. And there can be a drawback about that. And this is the same with picture. You know, people who are experts in picture, when they see one picture, they are no more able to see that picture are arts. And a painting is a unique thing. And you have to communicate with the painting and to see it as a piece of art and to forget that this is Impressionism, etc., Monet, etc., etc. And you see where I want to go. Of course, this is the same with patients. Perhaps we shouldn't be too expert. We should remain a little bit naive where we are in front of a patient and to say, this is a unique person. Perhaps it is an impressionist person. Perhaps it is a cubist. Perhaps it is something else. But just forget it and engage with this person. Thank you for your attention.